Hey, everybody. Welcome to another Breast Cancer Answers Live interview. I'm Dr. Jay Harness, co founder and medical director at Breast Cancer Answers. And we have a special treat for you today because we're going to be talking about the best decisions that you can make about breast reconstruction. And my guest is a fantastic plastic surgeon from San Antonio, Texas, Dr. Minas Chrysopoulos. And I butchered it. And I even, Minas, I even practiced and I still did it. But his friends and colleague in San Antonio refer to him as Dr. C. So we'll also call him Dr. C. Anyway. Minas is the president of PRMA Plastic Surgery Group in San Antonio. One of the reasons that he and I are connected is he is the creator of the Breast Advocate app, which is, we're going to talk about that later on during our interview. And then incredibly, I found out about this last night. He's the co-founder of Invisible Scars Advanced Scar Therapy. And I went on that website and found it to be really fascinating. So Minas, welcome to the live broadcast. How are you, my friend?
Oh, I'm great. Thanks so much for inviting me.
Oh, it's truly my honor and my pleasure. So you and I have had all sorts of conversations as we've gotten to know each other better about shared decision-making, about making really good decisions for women who are looking at a mastectomy, about reconstruction. I'm going to turn the ball over to you because you deal as a plastic surgeon on almost a daily basis with the fears that women have, with their concerns. See, how am I going to look? Is there going to be sensation? So, Minas, carry on, my friend.
Yeah, it's we see ladies and men, for that matter, because men get breast cancer too.
Sure.
We see folks from all over, and as you mentioned, we've grown to know more about each other through our common interests of shared decision making, which is it's been the philosophy behind our practice for many years, and it was the reason for creating the Breast Advocate app. And the take-home message is that there are lots of options for people, especially when it comes to breast cancer surgery, whether they have a lumpectomy, whether they have reconstruction at the same time as their lumpectomy, known as oncoplastic surgery, whether they have a mastectomy on one side, a mastectomy of the healthy breast too. That's a huge area of debate and anxiety for patients. Whether they go flat and have no reconstruction, that is an option that has to be discussed, because that too has aesthetic implications, and there's a right way to do it and a wrong way to do it. And then for breast reconstruction specifically, there's no one best way. We talk about tissue, the patient's own tissue being the gold standard, and in many ways it is. It's natural, it's soft, it provides the best option in terms of restoring some feeling, but you can get phenomenal reconstructions with implants too. So I think where we come together and agree very quickly, it seems, Jay, is that the final option that the patient chooses isn't the most important thing. The most important thing is the conversation, it's the choices that are presented, it's physicians listening to what the patient brings to the table, their preferences, their values, their situation, and just their diagnosis. So I think that's probably, that summarizes how I feel about breast cancer surgery in general, and specifically about breast reconstruction.
Well, that's a beautiful overview. And as you and I discussed last night, unfortunately, there's a fair number of patients who aren't presented with all these different options. But let's break it down a little bit. Let's say a patient is, let's say, gene positive or has multicentric disease and needs a mastectomy. Has nipple-sparing mastectomy risen a lot to a standard of care there in San Antonio?
Absolutely. So we were actually the ones, so PRMA, that's my practice, we were the ones who actually introduced nipple sparing to the community many, many years ago. And we're very happy to see that more and more breast surgeons have adopted it. It really has become standard of care. We now have the data as well to show that it doesn't impact breast cancer care and outcomes in any way when performed in the appropriate candidates. So in terms of reconstruction, it really does add tremendously to the final cosmetic result. Women do need to understand that saving the nipple doesn't mean that they save their sensation, their feeling. When it comes to breast reconstruction, I think plastic surgeons as a group, we really haven't been fair to patients when we talk about nipple sparing and even about breast reconstruction. I know I used to tell ladies, whilst talking about tissue options and using their own tissue for reconstruction, I used to say things like, well, your breast will feel natural. And well, what I was really saying was the breast will feel natural when I examine you. Because in terms of what the patient would feel, the sensation would be gone in the vast majority of cases. So you got to be specific in what you mean by feel.
Yeah, spot on, man. I absolutely agree with you completely.
Yeah.
So what, as you know, in the headlines recently, there's been a lot of concern about implants, textured implants, getting the old textured implants out. You must be dealing with this on a regular basis. So why don't you give us your overview about? I've had patients say, I don't want any foreign body in me, and I'm going to have them changed out, like having your tires changed out in your car in 10 years or something of that sort. Dennis, jump into that debate, will you, and enlighten our audience?
Yeah, for sure. So the news really has been dominated by ALCL, or specifically BIA ALCL. So let me break that down. So that stands for breast implant associated anaplastic large cell lymphoma. So people would just refer to it as ALCL. It's not a type of breast cancer, even though the implant is in the breast, and this cancer occurs in relation to specifically textured implants. But ALCL is a type of non-Hodgkin's lymphoma, so it's a cancer of the immune system. It's very difficult to pin down exactly how many cases have happened. In terms of confirmed cases, now by confirmed, I mean we have medical records, we can go through them, we can really be very specific and 100% confirm this patient has ALCL. There have been 573 unique cases of this lymphoma and 33 patient deaths.
Wow.
So potentially very serious. Putting it in perspective in terms of the numbers, we're talking about a very, very, very small risk. The risk is, again, in terms of confirmed cases, the risk is tied to textured implants. Implants have a shell. So the filling is either saline or silicone. The type of filling doesn't seem to be related. This is all related to the outside of the implant, the shell. And what we know is that the implants that have a very, very aggressive kind of texturing that feels very rough, those surfaces, that aggressive texturing seems to generate a reaction in some people that leads to this immune reaction and this lymphoma.
Right.
It appears as sudden breast swelling
Right.
or a new mass. Those are the two most common.
Right,
Uh,
and the fluid that you get that builds up around the implant, it's critical that that be aspirated and cytology done of that fluid, correct?
Absolutely. There are very, very specific tests
Yeah,
that need to be performed. So if you remove the fluid and just, because implants can develop fluid around them,
sure.
it's very common. But that's usually a very small amount. We're talking about, a lady who's at least a year out from surgery. On average, it's 8 to 10 years out from surgery, where a lady will all of a sudden develop this rapidly expanding swelling or a new mass. So that has to be taken very, very seriously. And the treatment is usually curative. The treatment is removal of the implant and the capsule, the scar shell
Yep, yep.
around it.
Now,
So
Menace, this is absolutely fantastic information. But one of the things you and I talked about a little bit last night is called a breast implant illness. Can
yeah,
you enlighten our
well,
audience
yeah,
what that is?
yeah. That's the second thing that's been in the news recently. And social media has really enabled information being passed on and exchanged. And breast implant illness is something that has really come to our attention and has hit the news. I think it's been enabled by the ease with which messaging can occur these days in social media. It's a constellation of symptoms. Breast implant illness. It's fatigue. Uh, some people have chronic pain, a rash. Some people complain of a different body odor after getting their implants, irregular
Huh,
heart rate,
huh.
new anxiety, neurologic disorders, hair loss,
Huh.
endocrine abnormalities, so hormonal imbalance. So that's a big list of very, non-specific
Yeah, yeah.
issues that we have so far not been able to tie together in terms of finding a cause
Right.
specifically because of the implants.
It
Again,
almost sounds like it's an immune reaction of some sort, right? I mean,
right,
doesn't
absolutely.
it
And
sound to you that way?
yeah, it does. And just because we don't have any evidence of a possible link and a cause, doesn't mean that these issues aren't real.
Sure.
And it's also not, it's not really that new. It's just being talked about more again
Right.
because of the social media angle. But these sorts of issues, concerns, complaints from patients, if you look back in terms of case reports and in history, there have been patients complaining of these things for a while now. Again, though, when you consider that millions, many millions of women are
Right.
walking around with implants, and then you look at the very, very, very small number of women who complain of these issues, what we can say with a lot of confidence is that the vast majority of women do very well with their implants, and the vast majority don't have these issues.
Yeah, so we don't want to have patients have the feeling, oh, I heard about this breast implant illness. I don't
Right?
want implants. Because
Yeah.
I'm with you. I mean, at the practice that I've been at for 15 years at St. Joseph Hospital in Orange, California, 95% of our reconstructions are done with implants.
Yeah.
And the patients are doing extremely well. And there should not be sort of that fear factor, as
Yeah.
you said, that's really being promulgated on the social media. Now, there in San Antonio, I know you are a microvascular reconstruction guy as a plastic surgeon. I know I've watched some of your
Mhm.
advocacy for the deep flap. But percentage wise, what are we talking of for breast reconstruction in San Antonio? Is it 85% or so implant, 15%, 15% tissue? What would you say?
Well, no, it's more heavily skewed towards tissue because we're here and that's our
Okay.
core service. I mean, so it's, tissue reconstruction. It's what we're known for. So patients travel to us specifically for that. They come to us and they tell us, hey, listen, I've been thinking about this and that. I did my research and you're the guys I want to do mine.
Well, that's excellent. So why
Yeah.
don't you elaborate? Obviously, it's a bigger operation, moving tissue up with a deep flap, whatever. But
Mm-hmm.
why don't patients are coming to you for reasons,
Yeah.
and the advantages of autologous tissue versus implant. Why don't we weigh out the
Yeah.
pluses and minuses with each?
Yeah. So a lot of women, to your point, they just don't like the idea of anything foreign in their body.
Yep.
So implants, worldwide and definitely in the US, are at least 80% of women are reconstructed with implants. So that's the usual recommendation. And not all plastic surgeons offer the advanced tissue reconstructions that are available today that spare the patient's muscle. And really, we can take tissue from many different parts of the body based on how the patient carries extra tissue that they don't want. So it can be the lower abdomen, a little bit of a belly because of multiple pregnancies or what have you. We can use tissue from the thighs, saddlebag area, the upper
Yep.
part of the back of the thigh, just underneath the buttock. We can use buttock tissue. Wherever the lady has what she feels as excess, we can utilize. We've moved along now from the procedures that sacrifice the patient's muscle. We
Right.
very rarely perform those muscle sacrificing procedures. So we have ladies from all walks of life that are very active. And now because we're saving muscle, they don't have the risk of a hernia or functional loss. And tissue doesn't need to be replaced. It doesn't get hard over time. It doesn't leak. It doesn't rupture. Now we're doing nerve reconstructions with our tissue reconstruction. So we've actually been doing that for over 15 years. 15 years ago, people thought we were crazy and what we were doing was a sham. But now finally the conversation has caught up. So we're taking nerves with the tissue. For example, with the deep flap, which uses the lower abdomen, kind of like a tummy tuck, we're finding nerves that supply the belly skin. And when we transplant the tissue to the chest, we connect that nerve to a nerve that has been cut by the mastectomy. And that
Wow.
really improves the feeling that comes back. It's not
Wow.
the same as Mother Nature yet. We're part of a big multi-center trial to really analyze
Wow.
these results. But it's very, very exciting times. And, when you've got recommendations from the FDA and from implant manufacturers of having to replace your implants every 10 years and monitoring for silent rupture, because sometimes you can have a
Sure.
rupture in a silicone implant that you don't know
Sure.
about. A lot of women just say, Doc, I hear you about implants generally being very safe, but I just don't want to mess with it. And I'd rather just be natural.
All right. Well, outstanding. Now, just for my edification, if somebody after a mastectomy needs radiation therapy, you would
Yeah.
delay the tissue reconstruction, I'm assuming, until they've healed well after the radiation therapy. Is that fair?
Another great topic. We're actually excited. We're trying to start up a study to look at neoadjuvant radiation. So in women who have radiation, for them to have their chemotherapy up front and radiation up front, then the mastectomy and the immediate reconstruction.
Whoa.
So, yeah, that's
You know what? You've just opened up another subject for another interview. I want to hear more about this, man.
But to answer your question, the safest approach in terms of complication risk, the least complications are associated with delaying the tissue reconstruction until after the radiation. So the lady has the mastectomy, has the radiation, and then she comes back for the reconstruction, delayed so that the tissue isn't subjected to the potential damaging effects of the radiation.
You bet. Well, listen, thank you very much. As we get near the end of our time together,
Yeah.
I really want you to talk about your app,
Oh, thanks. Yeah.
the Breast Advocate app.
Really,
I've
I'm
looked
glad.
at it. It's really exciting. I want to congratulate you for being
Thank
the
you.
pioneer and creator of this. But
Thanks.
let's share with our audience about the Breast Advocate app.
Yeah, really very excited about it, and lots of your great content from breast cancer and breast cancer answers has been included.
Thank you.
You got some great videos, so we had to include that content for our patients. But basically, the app came about because of I personally treat 200 patients a year,
Okay.
so I feel I sleep well at night. I feel very proud of what I do, but that's only 200 patients. And I was hearing the same thing over and over. Patients weren't being given all the options. Some of them were a little upset, actually, because had they known about certain things up front, it would have changed what they opted to do. The app is a shared decision-making app. It uses the evidence that's out there, what we know, what's been published. It takes the patient's diagnosis, it asks them their preferences, they answer a series of questions, and then it provides recommendations that then they can take to their breast cancer team, their breast surgeon, their plastic surgeon, with these recommendations so that they can have the conversation with their healthcare team, with their surgical team that they want to have. So whether they're considering a lumpectomy or going flat or breast reconstruction, it doesn't matter. Whether they're a gene mutation carrier, whether they have an actual current cancer diagnosis, males, so this is for men too, anyone who's touched by breast cancer or the risk of developing it has this tool now, Breast Advocate, that uh, presents all the options in a very user-friendly way based on their individual preferences. So
Now,
it's been very, very powerful.
the app is available for both Apple and Android, correct?
Yeah, so if you go to breastadvocateapp.com, you can download it via the website there. It's free for patients, and it's available for iPhone, Android, and iPad.
Okay, awesome.
Yeah.
Well, listen, let's sort of bring this to a conclusion. Minas, we've been you and I are really strong advocates for a multidisciplinary approach. That's a large team of people involved with our breast cancer patients, including outstanding plastic surgeons like yourself, devoted breast surgeons like myself, radiologists, pathologists, medical oncologists, physical therapists, integrative medicine folks, et cetera, et cetera. I constantly want to emphasize to people watching videos like this, make sure that you're working with a multidisciplinary team. And if mastectomy is something that either the patient chooses or is really going to be necessary, then the shared decision making here is really very important with a really skilled plastic surgeon who this is their passion and this is their advocacy. Minas, what are your sort of final wrap up thoughts this has been a really wonderful interview as we bring this to closure?
Thanks, Jay. I think I would just like to stress that the best advocate for the patient is the patient themselves. So if you're not having the conversation you want to have, it's okay to look at other options. Not all physicians can offer absolutely everything, and some physicians may not be able to offer the approach that you think you may want. So it's important to do your research, advocate for yourself, and make sure. I know it's a very emotional time for most people. Most people don't have the luxury of time. But do your research, advocate for yourself, and get a second opinion. Use the Breast Advocate app. Just the consequences of the decision making. That's what you have to live with.
Oh, very,
So
very good. Those are great thoughts. Now, if people want to learn more about some of the really cutting edge things you're and your group are doing, your PRMA, is there a website for people to check out?
Yeah, absolutely. So prma-enhance.com.
Okay.
That's we have a very informative website and a very informative blog. Also on social media. So if you look up PRMA plastic surgery on any social media channel, will come up. So we're very active online. We have a great patient advocacy group out there to help pass information along also. So please look us up.
Cool. Well, Minas, I want to really thank you. I won't attempt to try and pronounce your last name again. Oh, my word, it's embarrassing. That's why they call you Dr. C, and we love it.
That's right.
Yeah, this has really been a wonderful time together. I want to thank our audience for participating with us today. I'm Dr. Jay Harness, wishing you all of the best. Remember, at Breast Cancer Answers, we're here from you. Stay tuned for future interviews and future coming events at Breast Cancer Answers. Have a blessed day.